Hi, welcome to my YouTube channel, and today I'll be talking about pleural effusion. Pleural effusion carries a major significance in septoCK, so let's go over its high yield facts. Okay, now we know that pleural effusion is defined as an accumulation of fluid between the visceral and parietal pleura, that is known as a pleural space. Okay, now there are two kinds of pleural effusions. Firstly, it could be transudative and it could be exudative. Transudative is due to changes in hydrostatic pressure and oncotic pressure. Okay, so and exudative is due to increased membrane permeability due to ongoing inflammation, which causes to increase the permeability of the capillaries around the visceral pleura. Okay, so now what is transudative pleural effusion? We just discussed that it's due to differences in hydrostatic and oncotic pressure, okay, which results in the fluid movement across the visceral pleura into the pleural space, okay, and the capillaries surrounding it. So from the capillaries, it enters the visceral pleura and then into the pleural space. So now the conditions that are associated with transudative pleural effusion includes cirrhosis, congestive heart failure, and nephrotic syndrome. Okay, these are the most commonly asked situations associated with transudative effusion. Okay, so how is it treated? It can only be treated, the transudative effusion can only be treated if you treat the underlying conditions associated with them. Like if someone has CHF, you need to treat CHF, the underlying conditions associated with them. Like if someone has CHF, you need to treat CHF, you need to manage CHF to prevent pleural effusion, okay? And to eliminate pleural effusion if that is the prior cause of it. However, exudative effusion is due to increased membrane permeability due to ongoing inflammation, okay? And where does that inflammation happens? Okay, so due to ongoing inflammation in the pleura and the lung, right? So that increases the capillary permeability. Now, exudative effusion requires a light criteria for extensive diagnosis, okay? And the light criteria defines an exudate having one of the following three things that I'm going to mention. Okay, that is the light criteria. So first is, as we all know, that we need to see the ratio. Okay, we're going to compare the ratio of the pleural fluid to the serum fluid. So firstly, the ratio of the pleural fluid protein to serum fluid protein should be more than 0.5. Okay, if it's more than 0.5, that matches the criteria, that matches the diagnosis of exudative effusion. Secondly, if the ratio of pleural fluid LDH to serum fluid LDH is more than 0.6, yes, it does. Thirdly, if the pleural fluid LDH lactate dehydrogenase is more than 2/3 of the upper limit of normal for serum LDH, so yes, it matches the criteria. That makes sense, right? Okay, so now what are the basic conditions that are involved with exudative pleural effusion? Firstly, it can be infection, ongoing infection, pneumonia, tuberculosis, bacterial infection, emphyema. It could be malignancy. It could be pancreatitis. It could be rheumatic pleurisy. Okay, so these are some of the causes associated with it. Okay, now what else do you have to remember in this? You need to know that pH. Okay, now the pH involving transudative and exudative fluid has some values. Like normal, pleural fluid pH is 7.60. Okay, but exudative effusions will have acidic pH, like will have pH towards the lower side, and that is between 7.3 to 7.45, whereas transudative effusions will have higher pH, which is in between 7.4 to 7.55. So remember that. And if there comes a patient to you who's having chest pain and progressive shortness of breath, weight loss, and there is evidence of pleural effusion on chest x-ray, so what would be your next step in management? So the answer is diagnostic thoracocentesis. Okay, so diagnostic thoracocentesis is the only way where you can determine that what's the cause of pleural effusion, whether it's transudative or whether it's exudative. Okay, and the other differences that you have to see in between transudate and exudate fluid is that transudate, it does not form clots or froth in physical appearance, but exudate forms clot or froth when it's shaken, and it can be either straw-colored fluid or hemorrhagic. If it's hemorrhagic or bloody, so it suspects a malignant etiology. Transudate has a specific gravity less than 1.016, but exudate has it more than 1.016. Okay, glucose level in transudate would be less than 60, but it would be more than 60. Transudate will have glucose level more than 60 and in exudate less than 60. Remember it in this way that exudate pleural effusion usually happens due to infections, and if it's a bacterial infection, so that would result in utilizing all the glucose that is present, so that will decrease the glucose. So exudative is due to causes the glucose to be less than 60. Now if it's in the range of 30 to 59, then it would suggest either malignant effusion, tuberous pleurisy, tuberculosis pleurisy, emphysema, pneumonia, esophageal rupture, or lupus pleuritis. If it's less than 30, then it shows that it could be either rheumatoid pleurisy or emphysema. Cholesterol is less than 60 in transudate, whereas in exudate it's more than 60. And total protein is less than 30 in transudate and more than 30 in exudate. Okay, and then we know about the pleural fluid. The Lights criteria is just for exudate. Okay, also one more thing. If they ask you about the etiology of for pleural effusion with high lymphocytic count, that is, if the pleural fluid have a lymphocytic count of more than 50%, what do you think would be the etiologies? Like, what differentials would come to your mind? It could be cancer, it could be tuberculosis, or it could be fungal. It could be a fungal infection. So high lymphocyte count with high adenosine amynase also equals to tuberculosis. Okay, so remember that if the pleural fluid has a high lymphocyte count with high adenosine amynase, that is tuberculosis. Okay, yes, and for tuberculosis, the smears are negative. We know that negative for acid-fast bacilli. So diagnosis is usually required via pleural biopsy. So that would show pleural granulomas. In my next video, I'll be talking about the parapneumonic effusion.